Hello, everyone. My name is Sarah. I'm a resident at Cleveland Clinic. Thank you for the opportunity to present on our long-term effects of IPOM mesh. These are our disclosures. So how concerned should we be about intraperitoneal mesh? It's kind of a controversial topic, and people usually pick one side or the other. Everybody has heard of horrible complications of bowel eroding into mesh, causing fistulas, terrible intra-abdominal adhesions. So there's a lot of fear in general. This is one of the highly cited series on intraperitoneal mesh that has kind of contributed to a lot of this fear by Hom et al., where they looked at patients who had operations between 1992 to 2005. They compared patients who had intraperitoneal mesh versus extraperitoneal mesh, and then subsequently had reoperations to look at complications that occurred during those operations. And they reported that the intraperitoneal mesh had a significantly higher chance of a lot of really bad complications, like need for bowel resection during surgery, perforation of the small bowel identified on surgery, perioperative mortality, and fistula postoperatively. It is important to note that these were uncoated polypropylene meshes that were placed in the intraperitoneal position. And there's current guidelines in place that really strongly recommend that mesh should be placed in the retromuscular plane rather than intraperitoneal plane, partially due to these concerns for mesh complications and concern for higher recurrence rates in intraperitoneal mesh. One of our best series, though, in the literature, looking at long-term complications of intraperitoneal versus extraperitoneal mesh actually comes from the Danish Hernia Registry. Kokotovic et al. Reported 5-year outcomes of patients who had mesh in various places. And they really found that the long-term complications of mesh-related complications was about 5%, and was the same regardless of the location of the mesh. And this was a fairly recent study, but we were curious in our contemporaries cohort of patients who had minimally invasive IPOM mesh placed, what were the long-term mesh complications that we were seeing. So this was a query of the Abdominal Core Health Quality Collaborative Registry, which is a nationwide hernia-specific registry that surgeons prospectively enter granular details about hernia repairs. And there's also patient-entered outcomes that we collect that abstractors can also contact the patients to input. So this is our inclusion-exclusion. The patients had to have at least the ability to have at least 3-year follow-up that we considered long-term. We excluded anybody with stomas or diastases, any open repairs. We restricted to only intraperitoneal mesh placement, and we only included our institution because we knew it was a homogeneous data set, and we also had the ability to supplement the long-term outcome by contacting the patients. These are just a few of the outcome measurements that we used. So hernia recurrence was defined on a pragmatic definition, where a CT scan is valued at a higher, is weighted higher than a clinical exam, which is weighted higher than a patient-reported bulge on the hernia recurrence inventory questionnaire. Pain is measured by the PROMIS pain intensity scale, where lower numbers are better, and 30.7 is the lowest possible score. And then quality of life is measured by the Hercules, where a higher score indicates a better quality of life. So we had 256 of those 325 patients we identified had follow-up at 3 years or greater. The median was about 3.6 years overall. And this is just baseline demographics. They were fairly healthy patients, low incidence of a lot of comorbidities. And then some of the operative details, they were mostly clean, elective cases, slightly more laparoscopic than robotic, and median width was about 4 centimeters. When we looked at reoperations, there was only 2 reoperations in this cohort for mesh-related issues. One was a mesh that had to be explanted for chronic pain, and one was unexplained at the time of a colon cancer operation where the colon cancer had eroded into the mesh. And then we had 16 other abdominal operations. 5 of those were for recurrences, and then 9 were unrelated intra-abdominal pathologies. 1 port site hernia on a robotic patient, and then 1 adhesive small bowel obstruction about a month after surgery that had the surgeon noted that there was no involvement to the mesh. And then this is just the recurrence. Obviously, over time, the Kaplan-Meier decreases pretty low because our follow-up diminishes as we get farther out. But we had quite a lot of radiographic follow-up for these patients. 21% recurrence rate overall for that. When we look at the patient-reported outcomes, the quality of life increased 30 days and then up to 1 year. And then it was a pretty consistent, it held pretty well. It stayed better. And then same trend for pain. Pain decreased after 30 days to 1 year and then stayed persistently well. So in conclusion, in this series of contemporary MIS IPOM repairs, we found a very low rate of mesh-related complications. Reoperations for recurrence were also rare, and patients did better. They had better quality of life, lower pain. So I think it's safe, and people don't have to be too worried if they like to do IPOMs. Thank you.